Hello and welcome to another exciting lecture for Introduction to Psychology. In this one, we will be looking at some specific disorders within the domain of abnormal psychology. We're going to look at the developmental disorders, which are disorders that are relating usually or typically originating in childhood, and then we'll also look at the neurocognitive disorders, which are the things that usually occur later in life. So in this set of slides, we're going to start with the developmental disorders. We're going to look at things like ADHD. We'll look at the specific learning disorders. We'll talk about autism. We'll look at conduct disorder. Then we'll switch over to the neurocognitive disorders, looking at Alzheimer's and a bunch of other neurocognitive disorders that are similar in many ways to Alzheimer's but have different causes. For the rest of these slides, I'm going to talk about the neurodevelopmental disorders real quick. And it's kind of amusing that I've got like 8 or 9 slides to talk about what is classified as developmental psychopathology. That is, the disorders that originate in infancy, childhood, or adolescence. And these are disorders that tend to be neurological in origin, that you could take an entire semester talking about, and I'm going to talk about in the next 10 to 15 minutes. That being said, they're pretty interesting disorders. Things like ADHD, specific learning disorder, autism, intellectual disability, some communications and motor disorders, some behavioral disorders. We're not going to talk about all of these, but these are the main ones that fall under what would be classified as neurodevelopmental disorders or developmental psychopathology. First one we're going to talk about is ADHD. Everybody should know what ADHD is, but ADHD, attention deficit hyperactivity disorder. Its central features include inattention, overactivity, impulsivity, these types of things. And it's associated with impairments in behavior, cognition, and social and academic problems. So those with ADHD tend to have issues in many domains. In the DSM-5, there's symptom types. So it's been classified into types. Predominantly inattentive, that's individuals who are just inattentive. Predominantly hyperactive impulsive, individuals that just have the hyperactive impulsive, or combined with both. And what these present into is 3 subtypes called inattentive, hyperactive impulsive, and combined. And as you see here in this, majority of people are combined. One of the issues here, people think that ADHD is overdiagnosed, and in actuality, it's probably both overdiagnosed and underdiagnosed. How does that make sense? Well, what I mean by that is, in some situations, it's overdiagnosed. What's been found is that children with sleep apnea, we talked about that before, it's where they stop breathing in their sleep. Children with sleep apnea actually present with the same symptoms of ADHD and tend to get diagnosed as ADHD. So in that case, it's overdiagnosed. Instead of the apnea being diagnosed and treated, they're getting treated for ADHD when they don't really have ADHD, they just have a problem getting enough sleep. In those cases, it's overdiagnosed. However, it's believed to be underdiagnosed in girls. Why is that the case? Well, that's the case because if an individual is hyperactive, if an individual is inattentive, if they are, let's look at mainly the inattentive side. If an individual is inattentive, let's say you've got a boy and a girl who are both inattentive. They both stare out the window, they both come across as shy, that type of thing. Well, you expect a girl, society expects a girl, right or wrong, society expects a girl to be more shy. So she might not get diagnosed. A boy, that's abnormal. He's more likely to be diagnosed. So when it comes to specifically the inattentive type, girls may be underdiagnosed. Girls who should be diagnosed are being underdiagnosed. Next disorder we're going to talk about is specific learning disorder. So specific learning disorder, we're not going to spend too much time on this, but this is where an individual has academic problems in reading, writing, or math. One of the three, or more than one, but at least one of the three. And the performance for that individual is substantially below expected levels for their age, and the problem has to persist for 6 months despite targeted intervention. And here's specific learning disorders is a kind of an interesting one, because this, of all of the disorders, this is the one that's kind of the most transient, meaning that individuals will have a specific learning disorder and then they may overcome it. Many of them overcome it. Not may, many do overcome. I give myself as an example. I had the specific learning disorder of writing when I was in 3rd grade. I had it for 2nd and 3rd grade. Into 3rd grade, and for the second half of 3rd grade into 4th grade, I got targeted intervention, and now I have no problem with writing. It actually turned out my major problem with writing is how I was holding the pencil, and that is I was holding the pencil in a way that I couldn't see the letters, and when you can't see the letters, your writing tends to be sloppier. Once I got corrected on how to hold the pencil and write in a way where I could see what I was writing rather than holding the pencil in a way that was blocking what I was writing, that was my major issue there. So specific learning disorders are disorders that in reading, writing, or math that tend to be overcome with time and intervention. Next one we're going to talk about for a few slides here is autism. So autism, what is now classified as autism spectrum disorder. Autism spectrum disorder, it's now no longer a bunch of different individual disorders as it used to be. It's now a spectrum. As I said, the DSM-5 is trying to go to spectrums. This is one of the cases where they did go to a spectrum. So this is where problems occur in language, socialization, and cognition. The problems may span many life areas, and the problem in describing it as a spectrum is really key here, because two individuals with autism may have entirely different symptoms. That is because these symptoms cover a wide range of things that have similar types of outcomes. So they might have issues with language, issues with social awareness, issues with information processing, sensory processing, repetitive behaviors, these types of things. And there tends to be two main areas of impairment: communication and social interaction. And it's important to note here that 25% of children don't acquire effective speech with autism. So they don't have effective communication at all with speech. Interesting enough, we're finding out that it's not that they're not able to communicate, it's that they just can't put it into words. So if they're given a tablet with pictures on it and they can hit different pictures to communicate what they're trying to go for, that works. But as far as their actual ability to speak, that's what's hindered. Another common characteristic is restricted or repetitive patterns of behavior, interest, or activities. And this, a lot of the times when you talk about children with autism that are savants, savant is being especially good at something. First of all, most children with autism are not savants. That's actually a very small percentage. But most of them that we classify as savants, what ends up happening is they're a savant because their interest is so restricted that they become so knowledgeable or so good at that thing that they appear as a savant. One that I heard explained was a kid that was interested in air conditioners. He was a 6 or 7 year old that was interested in air conditioners. Well, because he was so interested in air conditioners, it's all he thought about, it's all he looked at, it's all he researched, all of that. He knew more about air conditioners than even people who were working in the air conditioning field, because that's the only thing his mind did, was thought about and worked on air conditioners. So you see this quite often in various different specializations, so to say, where you've got a kid with such restricted interests that they appear to be like savant-like. Repetitive and restricted behavior is another one. That's one of the main treatments for autism, is to have a schedule, a routine. That is because individuals with autism, many of them need a routine, or it causes them severe stress and anxiety. So, defining characteristics of autism are failure to develop age-appropriate social relationships. And this can come in many different ways: trouble initiating and maintaining a relationship, trouble with nonverbal as well as verbal communication. They may lack appropriate expressions or tones, so as well as being able to interpret expressions. Children with autism tend to have more difficulty identifying what people's facial expressions are, what their emotions are. And children with autism have a higher tendency to not express emotions correctly. And a big trouble with joint reciprocity, that is deficits in joint attention. So ability to communicate interest with another person at the same time. And when it comes to the social side of autism, this is the big component, this failure to develop age-appropriate social relationships. And as I kind of already said, but those with autism have a preference for the status quo, this maintenance of sameness. So severe forms will have stereotyped or ritualistic behavior, rocking, spinning, waving hands, twirling their hair, those types of things. Less severe form will result in intense interest in very specific subjects. And I already talked about that, having restricted areas of interest that can compound difficulties relating with others. That kid that I talked about that had an interest in air conditioners. If you didn't have an interest in air conditioners, he didn't want to talk to you because that was all he was interested in. And if you tried to talk to him, he would try to direct the conversation back to air conditioners because it was just such a restricted interest in his mind. So there was benefits. He could tell you exactly what a specific air conditioner would do, exactly how energy efficient it was, exactly how much area it could theoretically cover, exactly what voltage it needed, all of that. He could tell you all of that stuff. But if you tried to talk about anything else, he would get upset. So there's advantages and disadvantages, clearly. And the last thing I want to talk about with autism, so I should have talked about treatments, so I'll just briefly talk about treatments. Treatments is just focused therapy. There's a big push now to get children with autism into public schools or into schools with their peers, and to get them to that point, there's this focused therapy. I went to a place that did focused therapy on 4, 5, and 6-year-olds with autism, and it was basically in a outbuilding of a school, and their entire objective was to get those kids able to be incorporated with the normal school. And even if they needed, let's say, a special care worker to go through the normal classes with them, that might have been the thing, but that was their goal, is to get those kids in the normal classrooms. So it's just very focused therapy. And this is the other thing, I should have had a slide on this, I'm sorry that I didn't, but that one of the most important things when it comes to treatment of children with autism is early intervention. So some psychologists, some doctors, some psychiatrists don't like to diagnose autism until the child's 3 or 4 years old. Autism symptoms start early. 1 to 2 years old, you can start seeing autism symptoms. Those children who start to get treatment and therapy as early as 1 to 2 years old have by far the best long-term outcomes. So treatment as early as possible. If a doctor says they won't diagnose a child with autism before the age of 4, go to another doctor, because the earlier you can get a child diagnosed, the earlier they can get treatment, the better long-term outcomes. Now let's talk about something just as serious as getting early treatment, and that is vaccines. So there is this belief that vaccines cause autism. This belief that vaccines cause autism came from an individual called Andrew Wakefield. Andrew Wakefield was, keyword was, a doctor in England. He was a British doctor. He has since lost his medical license, but he was a British doctor who did a study on children with autism. And his study said that vaccines caused autism. There was some major issues though. And his study basically is started the whole anti-vax movement. And there are children dying now because of this doctor in this study. If I had my way, he would be charged with murder, because his study that he did basically led to children dying. Now, if his study was just a study where there was an issue with the study, or something like he got results and his results indicated that it was causing autism, but it was just something that can happen in science where it indicated it, but it wasn't effective. If it was just that, then I wouldn't hold him responsible. But that isn't the issue. The issue is twofold. First off, his study only had 12 participants. A study of only 12 participants, the sample size is so low that the effectiveness, the effect of the power of his study is just pretty much obsolete because it only had 12 participants. Second off, it's turned out that 4 of the 12 participants that were reported as having autism in the study didn't even have autism, do not have autism. So 4 of 12 didn't even have it. But the most damning piece of evidence, the most thing that makes him the most responsible is he owned, Andrew Wakefield owned a patent to a competing vaccine to the MMR. The MMR vaccine was the vaccine he was saying caused autism. He owned a patent to a competing vaccine, so if the MMR got taken off the shelves, he would make a whole bunch of money. He had a vested financial interest in saying that this other vaccine caused autism. Since then, there's been studies done with millions, not 12, millions of participants. Millions of kids have been looked at. And it turns out children who get vaccines and children who don't get vaccines have the exact same rates of autism, meaning there is absolutely no link between vaccines and autism. I was teaching developmental a few years ago, and I had one of my students who was older who had a child, and her child had autism, and she fully believed that vaccines caused autism and nothing I was going to say was going to change her mind. And that's the problem. The problem is our minds we take and we read something and we like to explain why certain things happen. We like to explain bad things that happen. So getting autism is considered a bad thing. We want to explain it. Well, it just so happens the normal time children get vaccines happens at about the same time as autism symptoms start showing. So what does that mean? That means that there's in our minds a correlation between the two because they happen at the same time. There's not actually a correlation between the two, but because they're happening at about the same time, our minds make this correlation. Even if there's definitely no causation, our minds make this correlation. And because our minds make this correlation, our minds start to attribute cause. And other people, Jenny McCarthy came out and said her son had autism and vaccines caused it, and so she was a celebrity who came out and said it, and now the anti-vax movement's just grown from there. The funny thing is Jenny McCarthy's son doesn't have autism either. He was misdiagnosed. So she came out saying vaccines cause her son to have autism, and he doesn't even have autism. Just one thing after another. And when we look at large-scale studies, it just doesn't stand up. There is absolutely no link between autism and vaccines. Mercury was rumored to increase the autism risk. Mercury's been out of the MMR vaccine for many years. And even when it was in the MMR vaccine, it was in levels lower than you get from eating fish. So it's not that it's an issue. And here's the thing. When it comes down to it, and I know I'm soapboxing, I've been talking a long time about this issue because it is I'm very passionate about this issue. It is a very important issue. Let's say for a second that vaccines did cause autism. They don't. We know they don't. We know from large-scale studies that they don't. But let's say for just 1 second that they did. The health risk of not vaccinating kids is greater than, not just greater than, but much greater than the risk of a child getting autism from vaccines. So even if vaccines did cause autism, which again they don't, children should still be vaccinated because the health risk of being unvaccinated is way worse than getting autism. Okay, I'll get off my soapbox. I think you get my point here. We know, science knows that vaccines don't cause autism. It's very unfortunate that there's large groups of anti-vaxxers out there now, all because one person wanted to get his vaccine, wanted to make money off from his vaccine by getting another vaccine taken off the shelves. As I said, he should be locked away for that. Alright, the last disorder I'll talk about, just real quick, real brief, is conduct disorder. So conduct disorder, it's a repetitive pattern and persistent pattern of behaving that's been going on for at least a year that violates established social rules, the rights of others. This is beyond boys being boys. This is beyond normal behavior. This is when a child has behavior that is basically destructive and violent and aggressive. So aggressive behavior such as threatening to harm people, abusing or killing animals, destroying property, being deceitful, stealing, these are all things that in children are classified as a conduct disorder. There is a relationship between basically younger age levels of conduct disorder, adolescent conduct disorder, and adulthood antisocial personality disorder, which we'll talk about when we get to the personality disorders. Next, we're going to talk about neurocognitive disorders. So neurocognitive disorders are any disorder that affects learning, memory, consciousness. Essentially, they're things that affect cognition directly. Most of these will develop later in life, though some can develop earlier. Some can even develop in childhood. But most of them we're going to talk about right now are things that develop as people get older, though one of them we'll look at does start when people are middle-aged. There are some specific types of neurocognitive disorders we'll be looking at. First, we'll talk about delirium and what is delirium, and how this delirium is basically outside of the neurocognitive disorders, because delirium is something that you can even force with things like drugs. Then we'll look at the major or mild neurocognitive disorders, and how that's just the broad cognitive deterioration that affects multiple domains. So within this, you've got things like Alzheimer's and Lewy body disorder, things like that we'll talk about. And then when we're talking about the neurocognitive disorders, we have to look at the amnesic. We're not really going to get into those too much, but amnesic are going to refer to problems with memories that may occur in a neurocognitive disorder. So we talked about the amnesic things earlier when we talked about memory. Now we're just going to refer to the fact that the amnesic effects can arise in neurocognitive disorders as well, hence why things like Alzheimer's, people with Alzheimer's have an effect of loss of memory. So let's start with delirium. So delirium isn't necessarily directly a neurocognitive disorder. Delirium is instead a category or a status that is separate from but part of many neurocognitive disorders. So what is delirium? Well, its central feature is impaired consciousness or cognition. It's something that can develop rapidly over several hours or days. Sorry about the cat meowing in the background. The person will appear confused, disoriented, inattentive. There can be memory deficits, language deficits. But the one thing with delirium is delirium can clear up, and delirium can be caused. So things like ecstasy, bath salts, these can cause a type of delirium that is very similar to the type that is caused by some disorders. So when we talk about delirium, we're basically talking about the general status of impaired consciousness or cognition. Now we will get into the actual neurocognitive disorders. So when we're into that, we're going to look at things like dementia and the stages of the neurocognitive disorders. So this goes beyond the delirium, which can be transient, it can come, it can go, it can have a short or a long onset, but then it can in some cases disappear, especially when it's due to outside factors. On the other hand, dementia is a gradual deterioration of brain functioning. So this is where the brain is just deteriorating gradually over time. If you're engaging with a person on a daily basis, you may not even notice it. So there's a deterioration in judgment, in memory, in language, in advanced cognitive processes. It does have many causes, and in some cases it can be reversible, but in other cases it can be irreversible. We have at this moment in time no cure or long-term treatment for most of the neurocognitive disorders. When I talk about this though, this gradual deterioration, one thing I do have to point out is that part of this gradual deterioration is people start making accommodations. They basically use other parts of their brain, they use other things to accommodate this loss. It's the same thing people do that are losing their senses, their sight, their hearing, stuff like that. They use tricks that they learn over time to make up for this loss. So that is one of the other things that can make it harder to tell that this is going on until it's too late in many cases. Let's look at the early stages. So the early stages, typically what you've got going on here is that you're going to start having memory impairments, maybe visual spatial skill impairments. So if asked to point at something or touch your nose or draw stuff like that, where there's impairments in that start to occur. So actually beyond memory, because memory is something that's hard to measure in many ways, as we talked about when we talked about memory. So that's not always a good judge of when someone is developing a neurocognitive disorder. On the other hand, these visual spatial skills, there are tests that you can do that can really early on tell if you're in the early stages of these neurocognitive disorders. This was one of the things few years ago when they were talking about Trump actually having some cognitive declines and possibly having a neurocognitive disorder. One of the things they pointed out was that he was having difficulty with a lot of visual spatial skills, and that being an indicator that he was in the early stages of neurocognitive decline. Other things that can occur is facial agnosia, the inability to recognize familiar faces. This comes with memory. But it also comes with the facial processing as well. Then there's other things that can appear as well, delusions, just like with schizophrenia, apathy, depression, agitation, aggression. These different types of things can be early indicators that something is going on. Then in the later stages, cognitive functioning will continue to deteriorate, eventually typically coming to a point where total support is needed to carry out day-to-day activities. When you can't feed yourself, when you can't remember where the bathroom is, when you can't remember where the kitchen is, things like that, you need complete support to carry out these activities. And then one of the things that occurs here, though, is there's an increased risk of early death because of inactivity. As when a person is not fully cognitively functioning, they tend to just sit there, either lay there in bed or sit there on the couch doing nothing. So one of the things I've talked about earlier when I was talking about developmental, how one of the best things you can do later in life is use your brain to extend your cognitive functioning, is use your brain. Well, if you're forced to not be able to use it, such as with a neurocognitive disorder, then you get a rapid deterioration that can occur from that can lead to the onset of other illnesses as well due to lethargy and stagnation. Let's talk about Alzheimer's now. So that was before we were talking about in general. Now we're going to talk in these next few slides about some specific neurocognitive disorders. So the first one is Alzheimer's. And why do we talk about this first? And because it is about half of neurocognitive disorders are due to Alzheimer's. That being said, there's some belief now that Alzheimer's is slightly overdiagnosed. It's because, and we'll get to in the second one we'll get to after we're talking about Alzheimer's, is underdiagnosed and misinterpreted as Alzheimer's quite often. So take the half of neurocognitive disorders are Alzheimer's with kind of a little bit of skepticism, but at the same time it's still a large percentage. It is still more than any of the other disorders. So for the clinical features of Alzheimer's, it's something that typically will develop gradually and steadily. There are instances where it will go slower. If you're taking an abnormal class, I would go into this in much more depth. But one of the things that's interesting is that those who are educated, those who have higher IQ, those who have more learning, and those who continue to use their brain, for them, Alzheimer's develops different. For them, Alzheimer's doesn't develop gradually and steadily, it develops abruptly. It actually occurs at about the same age as the later stages of other people with Alzheimer's. The only difference is they don't get the early stages, they get the later stages at about the same time, if that makes sense. And it basically is believed that education and using your brain is a buffer against the development of Alzheimer's, but not the outcome of Alzheimer's. So somebody who's going to develop Alzheimer's, whether you've got good education, whether you use your brain or not, that it develops, you'll get it regardless. However, you can stave off the early stages by doing those things. What's affected from Alzheimer's? Things like memory, orientation, judgment, reasoning. This is why people with Alzheimer's tend to do things like walk out of their house and walk into the street, because they've got judgment and reasoning deficiencies. Some additional symptoms can include agitation, confusion, or combativeness, and this is basically blamed on the fact that the people with Alzheimer's are trying to process the information and they can't, so they get irritated and combative about it, which can lead to depression and anxiety. So when we're looking at the deficits, some of the deficits that can come with Alzheimer's is aphasia, so difficulty with language. People in the later stages of Alzheimer's lose the ability to talk. Apraxia, which is impaired motor functioning. They lose the ability to move, especially fine motor movements. Agnosia, which is failure to recognize objects. They have difficulties with planning, organization, sequencing, abstract information, the basic cognitive abilities that we have as humans. So there becomes a negative impact on social and occupational functioning because of these deficits, because of these losses. So what is going on right now with Alzheimer's? Again, if I was teaching abnormal, I'd spend probably half a lecture or 10 plus slides on it, but I'm only, because we're an intro, I'm just spending 2 slides on it. But just one of the interesting things is a lot of new research. There's a lot of funding going into Alzheimer's research. A lot of new research is focusing on identifying the precursors to Alzheimer's to prevent further damage. If you can identify it earlier, you can possibly stave it off or push it back so it develops later, just like we know occurs in individuals with higher cognitive functioning already, those who are college educated, things like that. The next one we're going to talk about is vascular neurocognitive disorder. So what is vascular neurocognitive disorder? Another term for this is microstrokes. So this is caused by a blockage or damage to blood vessels, which then causes damage to the brain. So blood vessels get blocked in the neck or the brain. These blood vessels that get blocked cause small parts of the brain to die off. And its onset is often sudden, so it can occur from a major stroke, but in a lot of cases it occurs from microstrokes. These microstrokes are things a person isn't even aware they're having. Maybe they have a headache one day, and a week later they have another headache. 2 weeks later they have another headache, and 2 years later they're showing the same cognitive functioning as someone with Alzheimer's, because gradually over time, small portions of the brain died off due to these microstrokes. This actually happened to my grandfather. People thought he was getting Alzheimer's. It turned out he was having microstrokes, and basically different parts of the brain were dying off slowly and caused him to have impaired functioning very similar to Alzheimer's. When I was talking about Alzheimer's, I said that this one is often misdiagnosed. It is the second leading cause of neurocognitive disorders, and the doctors are getting better at diagnosing this, but it's still often misdiagnosed as Alzheimer's because there's this misunderstanding of what's going on. Most do require formal care in the later stages, just like with Alzheimer's, but the interesting thing with this disorder is that the patterns of impairment are variable. Why is that the case? It's because the different locations of the microstrokes or even major strokes will damage different parts of the brain, which will cause different deficits. Some people may have perfectly fine functioning memory, but may have difficulty with motor movement or difficulty with recognizing faces or language or things like that. Basically, this one comes down to the actual impairments an individual has depends on where the strokes are occurring. Next one we're going to talk about is very similar, the frontotemporal neurocognitive disorder. And this is when you have any damage to the frontal or temporal regions of the brain that are going to then affect personality, language, and behavior. So what ends up occurring is you get declines in appropriate behavior or declines in language. And what is going on here is that these disorders that may exist, they end up doing damage to the frontal lobe. And when we talked about cognition and memory, you know that the frontal lobe is very important in human cognition. Related to that is the neurocognitive disorder due to a TBI, a traumatic brain injury. So accidents are the leading cause of this, but now it's turning out that not just accidents, but things like sports are having a big effect on, or a big cause of this. For this, the symptoms can last anywhere from 1 week after the head injury. They can in some people last for the rest of someone's life. They can affect executive functioning, they can affect learning, they can affect memory. Memory loss is the most common symptom, as we talked about when we talked about memory earlier in the semester. We talked about how people with brain injuries, they lose memory of the things right before the event because the memories haven't consolidated. However, one of the issues here is football players or other athletes, especially any athletes that are in contact sports and that are in them for extended periods of time, they have repeated mini concussions. The repeated times where the brain is getting little bits of damage. It doesn't have that big of an effect on if it happens once, twice, even a few times, but what's actually occurring is, and they're finding this out more and more with football, that even a simple tackle can do very small amounts of damage to the brain. On its own, that's nothing really to be concerned about, because usually the brain will make up for that relatively quickly, and very minor damage isn't something that's noticeable. However, when it occurs over and over and over again on a daily basis, that damage adds up, to a point where you get actual neurocognitive issues. We see this a lot with hockey players that were bruisers, hockey players that were enforcers, the hockey players that basically were the fighters for teams. If you don't know much about hockey, in hockey, at least historically, it's not as much the case anymore. Teams would have players that were still good, but their main role was to fight and defend the players on the team that were more skill-based. So these players would be getting in fights night after night, and these fights ended up having long-term effects, and a lot of these old players now have memory issues. They have issues with other behaviors, things like that are just a result of this repeated fighting. It's the same thing you get with boxers. Boxers tend to have long-term cognitive issues because they had so many blows to the head. Next one we'll talk about is the Lewy body disease. So Lewy body disease is basically this is very, very similar to Alzheimer's. Actually, Alzheimer's is caused by essentially the same thing, just a different protein. In abnormal psychology, I like to add, and I'll just add that and ask that in this question because I'm actually saying it outright in the lecture. One of the questions I ask is, what is one of the known causes of Alzheimer's? And that is, and expect this as possibly a question, and that is that it's buildup of protein deposits in the brain. Lewy bodies are the same, so Lewy body disease is the same thing. That is these microscopic protein deposits that build up over time in the brain. So symptoms, just like Alzheimer's, are typically gradual, the onset of them, and you get a lot of very similar things to Alzheimer's, like impaired attention and alertness, and motor impairment, but you also get things like visual hallucinations with this, because Lewy bodies affect slightly different parts of the brain than Alzheimer's. It's actually different protein deposits that do it. So expect that to possibly be one of the questions if I sneak it in, that what is one of the leading causes of Alzheimer's, and that is protein deposit buildup. Next one we'll talk about is Parkinson's. So Parkinson's is an interesting one in that this one is genetic, and it is one that we have a lot of study on because Parkinson's can show up earlier in life. Just like Huntington's, Parkinson's can show up earlier. It's a degenerative brain disorder that does dopamine pathway damage. So about 1 out of every 1,000 people are affected worldwide, which is a pretty high number. One of the chief difficulties is motor problems, so where you get tremors, posture disorder, walking issues, speech issues. And one thing that does need to be pointed out is not all people who have Parkinson's will develop dementia in the sense of us looking at it as a neurocognitive disorder, in that there are those declines beyond just the physical declines. And roughly 75% survive for 10 plus years after the diagnosis. So it has a pretty good prognosis. However, again, the people with this tend to have issues with tremors, posture, stuff like that. One thing that is a positive here is there's been a lot of research done on Parkinson's, so there are treatments that can reduce the symptoms. There is no cure, but they can reduce the symptoms. Briefly, another one we'll talk about here is the neurocognitive disorder due to HIV. So one thing we know about HIV is people in later stages of HIV and into AIDS have neurological impairments, dementia. Not all of them, but it can develop in some. There can be impaired attention, forgetfulness, the cognitive slowness, social withdrawal, apathy, but this typically occurs in later stages, and due to what we know about treatments and stuff like this, it actually now only occurs in less than 10% of individuals who develop HIV. Giving them to you rapid fire now. The next one is Huntington's disease. So Huntington's disease is another genetic disease that can manifest with involuntary limb movements, typically occurs later in life, but can occur in middle life to some. And about, again, just like Parkinson's, not all develop neurocognitive disorder, but about 20 to 80%. Why is this such a wide range? Because we don't know enough. Develop a neurocognitive disorder, and in a sense, dementia follows what would be counted as a subcortical pattern, as in it goes through the subcortical region first into the cortical region. Next one we'll look at is Prion Disease. Prion Disease is a disease in which, again, another one in proteins in the brain. So just like Lewy bodies, just like Alzheimer's. So you see a lot of these are due to proteins in the brain. Well, this one, in this case, the proteins in the brain are reproduced rapidly and cause damage. There is no known treatments for prion diseases. It is always fatal. The one that is most known, most common, is mad cow disease. Prion disease basically can only be acquired through cannibalism, or, as it says here, accidental transmission, but that is actually rare because you have to get a transmission of the cells from another person's brain. So the cannibalism occurs through eating other brains. That's why it's linked to mad cow disease. Mad cow disease is in cattle where it can occur, but people can get it. And why does that occur? Well, because unfortunately in the past, and it's not done anymore, or at least it's really been curtailed because of mad cow disease, but what ends up happening is after a cattle are butchered, the meat is taken off, the remains, the carcass is basically ground up and fed to other cattle. Well, what ends up happening there is if one cow has the mad cow disease, now their brains are ground up and fed to other cattle get it. And this is a way that humans can get it too, accidentally, if this occurs, where humans end up eating any brain tissue from the cows with this prion disease. There are other prion diseases out there, but they, again, are rare, and really, like I said, it's hard to get because you have to take in blood or some part that came from the brain of an infected individual. So the next one, this one is just talked about because of the fact that it is related and it is actually self-caused. So what is this? This is substance medication-induced neurocognitive disorder. So this is basically in chronic drinkers. So about 50 to 70% of chronic heavy alcohol users show some cognitive impairment. And when I talk about these chronic heavy users, I'm not talking about binge drinkers here or casual drinkers. I'm talking about people who actually get like hammered drunk day after day after day. That is chronic heavy alcohol users. Actually, this disorder is much more prevalent in Russia because in Russia it is more common, it is more socially acceptable to be a heavy drinker. So people there tend to drink more and they drink heavier, and what ends up resulting is a much higher rate of this specific neurocognitive disorder in Russia due to that. 7% of heavy drinkers meet criteria for a neurocognitive disorder. So whereas 50 to 70% show some cognitive impairment, some memory problems, things like that, 7% actually meet the criteria for neurocognitive. And this comes from prolonged drug use, prolonged alcohol use, sedatives, hypnotics, inhalants, things like this that can just really cause brain damage is what they do. So, and what is scary here is the brain damage can be permanent. If you go through a phase in your 20s where you're using heavy drugs, where you're drinking lots of alcohol, you can cause brain damage that can affect you the rest of your life. And the symptoms here are very similar to Alzheimer's. where you've got memory impairment, the aphasias, the apraxias, the agnosias, the disturbed executive functioning, things like that. So it's just one of those things that I throw out as caution. This isn't something to be concerned about if you're a casual drinker. This is something to be concerned about if you're getting blackout drunk day after day after day. So let's look real quick at just some prevention of neurocognitive disorders. Really, again, like I said before with memory, use it or lose it, but along those lines, there's other things we know. So in adults that are at risk of getting some of these disorders like Alzheimer's, anti-inflammatory medications can actually reduce the risk of them occurring. Blood pressure, controlling blood pressure, not having high blood pressure, not smoking, an active social life. These are the types of things that can reduce your chances of having those microstrokes. There's other preventative efforts like increasing safety behaviors to reduce head trauma, such as wearing a helmet when riding a motorcycle, reducing exposure to neurotoxins and drugs, so such as if you're in an environment where you're constantly exposed to fumes, things like that, that can help here. I've told this story before. I don't know if I told it this semester, but I have a buddy who grew up in a town in Ohio, and there was a Rubbermaid plant in this town, and basically about 40 to 50% of people in this town, I don't remember the exact percentage, but a very high percentage of people in this town developed cancers of some sort. My buddy actually developed cancer on his spine and became paralyzed from the chest down. Along with that, a lot of people in town started to develop neurocognitive disorders, and it was because the Rubbermaid plant was basically dumping their chemicals from in their manufacturing process into the water supply, and people were exposed to these chemicals for years and years and years. Something just really scary to think about. I'm not sure where the lawsuits went with that. It's been a few years since I talked to that guy, but it's just one of those things to be concerned about. Okay, so just to wrap up this set of slides before we get to the next set next week that is treatments. So we talked about the developmental disorders, we looked at ADHD, we looked at the specific learning disorders, we went into autism, not as much as I would like, but we went into autism, talked about conduct disorder, then switched over to the neurocognitive disorders, in there talking about Alzheimer's and all the other neurocognitive disorders there, and just really a lot of that is scary, but it's one of those things that the more we know, the more research that's done, the more control we have over these things. All right, thanks. Come on back.